Good morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement, in for Dr. Steve Stites, our Chief Medical Officer. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio. This morning, KDHE Secretary Dr. Lee Norman is our guest, and we've got lots to talk about. But first, Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, is here with our numbers. How's it look this morning, Dana?
You know, numbers are still pretty good. 7 acute infections in the hospital, 2 in the ICU, 1 on the ventilator, 15 in that recovery period. So still numbers in that 20 to 30 range, which is a good place to be. Obviously, lower is better. Hays has 1 active infection as well. So,
all right. I'm sure we'll talk a little bit more about that here soon, but we're going to go right to Dr. Norman this morning. Welcome back, sir. I know you have an appointment in a few minutes that we need to make sure we get you to, so we'll jump right in. Yesterday, Kansas moved to vaccinating all 5 phases. Tell us a little bit about how that went and why the decision was made to really open things up now.
Yeah, great question. Good morning to you both. Good morning to all. We moved into phase 5 yesterday. So that means general population. So anybody in phases 1 through 5 that's 16 or older can get vaccinated now without particular regard to their essential work status or underlying medical conditions. We're the 8th state in the United States to do that. And I think it reflects the fact that we've been effective at getting one vaccine coming into the state. I've found out that some states have not taken all their allocation that could come to them because they didn't want to have any remain in inventory. We've taken a distinctly different approach, which is to give all the vaccine that we can, and if we have a little bit remaining in inventory, it gives us flexibility. So we're almost 1.3 million doses now that have gotten into people's arms. That's 43 out of every 100 Kansans. Remember a while back we had problems with data reporting. We've pretty well taken care of that, not in 100%, but we have we've moved beyond 20 states now that rank below us in terms of the percent being administered. So what we're finding, David, was what you would expect, and that is we had open appointments in some counties and some cities. So the way to take care of open appointments is to go into phase 5. It was a little sooner than we thought, but we're definitely ahead of schedule, and especially when you consider that we've done teachers and many high-risk populations. I think we're in pretty good stead. But I know we're going to talk today about the uptick around the country. Fortunately, we've not seen that yet in Kansas. We very well might. But we're okay now in terms of our trend lines going down in terms of deaths and cases hospitalized. But we're seeing a flattening off of the curve for hospitalized. We're seeing decreased total case volumes and decreased number of deaths trend line. But the number in hospitals is flattening out in a bad way. We don't want it to reverse. And there's some things we can do, but I know you're going to talk about that.
Yeah. I like the number 43 out of 100, out of every 100. That's a good feeling. I think we all know we want to get that higher quickly. Makes sense then at that point to really jump to anyone who's 16 and over and in phase. And, you know, we heard a lot of questions yesterday from viewers and from the media about showing concern or voicing concern about a shortage of vaccine if it became, I'll say, open season for anyone who wants a shot. Are you worried about that at all?
Not really. We started yesterday. There wasn't a major thunderclap and anything changed. We're just keep on trucking. I imagine in some areas, the people that had a hard time getting in already because of mobility problems or their shut-ins or for whatever reason are not able to get out, there's still going to be problems, but it won't be because other people are taking their spots, I don't think. What that really means is that we need to double down on the challenges that were already existing, the hard-to-reach population, minority groups, and others that have a hard time accessing transportation. But I think that we're going to be fine. We had over 158,000 doses delivered into the state of Kansas this week. That's I think the largest number. 16,500 of those are Johnson & Johnson. So we hope that those numbers will come back. The Pfizer and Moderna prime and boost doses are coming in the door. So and President Biden is talking about between now and April 19th, increasing the number of pharmacies that get direct allocation from the federal government. We don't see those doses. Those come directly to the pharmacies. I recommend the vaccinefinder.org website that's run by the CDC really is opening up at new avenues for people because the CDC has the ability to match up allocation of doses to places that have it in stock. So I think it's important for viewers and everybody to remember www.vaccinefinder.org. It's also, if you go to our kansasvaccine.gov site, there's a link to it directly. You put in a zip code and it tells you what pharmacies have it in stock. And that's something we don't have visibility. So that's something that people can take the bull by the horns and do it themselves. And I think people are having support with that.
Great. Thanks for the advice. You mentioned that there are some populations for mobility or whatever reason that are struggling to just get to a vaccination site. On the other hand, we talked yesterday to a patient and a viewer who said, even though I know the importance and I'm going to get this, I'm still hesitant. And we know that there are groups, whether they're geographically located or whether they're related to specific religious beliefs or other concerns that remain hesitant across the state. What are you seeing from that perspective, and how is your team working to help move those people to the point where they feel comfortable with the vaccine?
Yeah, it's a smart question. It takes an incredible amount of customizing, we're finding, because, for example, you talked about religious beliefs and the Johnson & Johnson, and I know Dr. Hawkinson has addressed the immortal cell lines and how a few very conservative Catholic leaders have said to their flock to against getting the J&J. So what we try to do is say, okay, well, let's find the Pfizer, the Moderna to hit a particular population and make it available. That's one group. Certain minority populations traditionally are vaccine hesitant, and we try to have, and I shouldn't say try to have, we have spokespersons from those communities and that are getting out the message, because they tend to, people have shown that they believe people who look and have similar life experiences to them. Their primary caregivers is another example of that. We have the Kansas Leadership Center we're working with that's doing hundreds of community forums that involve business leaders and faith leaders and the like. So a blanketed one approach fits all does not work. And to these smaller populations and subgroups, we have to go out to them, and we have a lot of campaigning going on with marketing and in many different languages. So it's taken a lot of customization, and I think we've risen to the occasion. We started on this with our advisory committee, which has all those tribal and various populations represented. So I think that the approach has been good. The uptake has been, quite honestly, a little slower than what I thought it would.
We might have lost Dr. Norman. There we go. I think he's back. We lost you right around the point where you were saying you thought the uptake was a little lower than you expected it to be.
Yeah, I don't know what happened to my connection here, but it was a little slower than what we thought it would be, but hopefully success will garner more success.
We've been working, I think, as we've shared here, with Johnson County and Wyandotte County, really since the beginning of vaccine availability, to work on these questions and conversations. And over the last week, really started to use our experts on this campus in different ways to connect to those communities, specifically with Wyandotte County, but also in Johnson. So Dr. Carrie Francis, one of our head and neck surgeons, who really is an expert on understanding the needs of, I'll say, diverse populations of all sorts, has really given us some great contacts to start working through leaders in the community to help with these problems. And I think you're right, Lee, those individualized approaches are really important in those conversations. So, I'll pivot for just a second. Last week, Rutgers University went to a mandatory vaccination policy for anyone who wanted to study in person. And we've talked a lot about mandatory vaccinations and potentially some challenges while a vaccine is only approved as an emergency use authorization. But what are your thoughts on this, and when the vaccines available will maybe move to full approval, and should universities take stances like this, like Rutgers?
It's controversial, and as a matter of fact, our state legislature is doing things so that by statute that can be prevented for businesses, academic institutions, and even healthcare settings. I personally think that an employer, for example, needs to match what is the safest thing for their work site and what is the safest thing for the people that come to them, whether they're patients or business patrons and the like. I think the flexibility should be given. I think that with the COVID-19 vaccine, I don't see that on our regulatory mandate anytime soon. Of course, as you point out, we can't do it as long as it's being offered under an EUA anyway. But that's something for a later date. I would not want to have that complicate the picture of getting it into people right now. It may be a conversation for the future, though.
Great, thanks. Well, while we have a few more minutes of your time, let's see if there are any reporter questions on the line.
I don't think we have reporters listening in this morning, but we have plenty of community questions. To follow up on the legislature question, Dr. Norman, Jennifer asked, she said it feels like the Kansas legislature is tying your hands or working against you, and she just wanted to know if you wanted to react to that.
Oh, yeah. This has not been easy sledding since May of 2020 with the Attorney General and the legislature progressively trying to, by statute, curtail what have been century-long public health successful practices by interfering with case investigation and contact tracing. And then in this session, of course, taking away the authorities of the state health officials, such as myself, and the county health officials, and leaving it to untrained medical people to make those decisions, I think is very short-sighted and ill-advised. That's going to raise some hackles by my having said that. But so much of this is being done about COVID-19, when in reality, people have to remember, we've got a big syphilis outbreak in Kansas. And Dr. Hawkinson, you're going to pale when you hear this. We have over 400 hepatitis A cases in less than a 12-month period, and we normally have 10. So let that sink in. Yeah. And all of these take the same public health measures of case investigation and contact tracing, and it's not a time to throw a bunch of obstacles in front of public health officials. And by the way, it makes it hard to recruit public health people, and it makes it hard to retain public health people who are the backbone of our disease prevention in these communities. So I think the legislature should stay involved and have conversations, but not do what it can do to derail long-standing, very successful public health interventions.
Yeah, I would agree. There are more things than COVID out there, and they are significant public health issues. Myself, I've had 2 of my HIV patients who've had just major cases of neurosyphilis. We know that's going around in the men who have sex with population, as well as hepatitis A. I've done hepatitis A investigations before for the Kansas City, Missouri Health Department when I worked in that infectious disease investigation, and that's a bad disease as well. So there are other things other than COVID out there.
I think it just is a great reminder that prevention of any sort, right, mm-hmm. whether it's for infectious diseases or really for any disease, any chronic disease, is actually a really important part of improving the health of our community, and we don't want to lose that for any reason. So, Jill.
Becca has a question for Dr. Norman. She wants to know, why is it so hard to find a place to get COVID testing? She said that some of the places that she had gone to before, like CVS mm-hmm. and Hy-Vee, were not doing it anymore.
I wasn't aware that they aren't doing it anymore. You can go to our website and find the testing locations at the kansasvaccine.gov. Because we're still doing a lot of testing. At this point in time, we've done over 3 million, between 3 and 4 million testings. I might have said that wrong on the website. Let me think about that for a second. We do have testing on our website. We are increasing the number of tests all the time. We're between 3 and 4 million now, and that puts us in pretty good stead compared to other states on a per capita basis. But it's interesting, and Dr. Wild, you brought this up at the top of this session, that as case volumes are going up in other states, there's 27 states where the case volumes are going up, the testing is going down, and that is exactly the wrong thing. So I would encourage the person who asked the question to go to our website, and because we have all the testing sites listed, and the state is quite well covered. You'll see a map with lots of little dots, and you can go to those dots and figure out where it is. We're still very busy testing, and including testing for the variants. We're doing more of the testing for all the various variants of concern, as we refer to them, both in terms of the genomic sequencing of the samples that we get from patients when they get tested, and also in the wastewater, which I've talked about a number of times. We're doing more and more variant testing in the wastewater as well.
And Becca, I'll just say, if you're near any of our facilities, we have testing appointments available. We haven't changed our strategy or our commitment to the community in that regard at all. So we can definitely help you there. If you're close to one of our facilities, we can make that as easy as possible.
Okay, we have got almost 3 minutes left, or 4 minutes. And by the way, Ashley in your office says, Dr. Norman, it's gogettested.com/Kansas. Gogettested.com/Kansas is your direct route. A couple of more questions for you. Zach wants to know, roughly how much vaccine does the state of Kansas get each week? And do you know what the pharmacies are getting? Because I think they're separate.
Yeah, we don't know exactly what the pharmacies get. I suspect we could find it out, but the feds put it to them directly. We're getting right in the kind of mid 150,000 doses. And I know for those of you that are good at math, you can figure out 150, like this week, 158,000 doses or so. How many weeks or months will it take us to get 2 doses of the Pfizer and Moderna into people, 1 dose of the Johnson & Johnson? We're thinking by May 1, we're going to hopefully have everybody immunized with at least 1 dose that wants to be. And that's why I will implore everybody to take seriously mask wearing and distancing, certainly through the end of April. And then we'll get back to you in May and beyond. It's a very fluid situation, obviously. David you might want to comment, I think, on Texas. And that's a great example of failure in terms of policymaking.
Yeah, and we can talk about that now, and it'll probably run us right to the end of your availability, Dr. Norman. But, I mentioned to our team here that I've seen a number of social media posts or things forwarded from friends who have said, hey, look, right, Texas opened up, and now for 17 days in a row, they have a decreasing case number, and that's related to opening up. And I thought, that's an interesting line of thinking. But one of the more important parts there is, I think we all have to remember that the disease transmission dynamics of this virus haven't changed for any reason. So the incubation period remains 2 to 14 days, with that sort of 5 to 10 or 5 to 12 days being the most common. But any changes we're seeing now in those numbers are due to things that happened 2 or 3 or even 4 weeks ago, behavior changes. And let's not forget, in Texas, for example, at that point in time, around 4 weeks ago, maybe 5 now, there was this little thing called cold weather and an ice storm, and people weren't out and about and moving nearly as much. And so just a reminder that the sort of the rules of this game are still, we're seeing the impacts of behavior changes a month ago right now. And the behavior changes called spring break will show up sometime in the next 2 or 3 weeks. So we can talk more about that if we need to. But I know, Lee, we are right at your time. You need to leave. Thanks for joining us today, and a very special Happy Doctor's Day to you and really all of the physicians out there. I'm sure we'll touch on that a little bit more. Anything you'd like to leave us with as you run off? Maybe we've lost him already. Yeah. Okay, then. Jill, any other community questions this morning?
Oh, yeah, we got quite a few.
Back if we want to.
Dr. Norman, you want to say your final goodbye?
Oh, gee, that sounds so final. 2 things. One is I can't believe we can turn an anesthesiologist into a public health doctor. That's good news. And then secondly, the reason I'm breaking off a little early, I'm going to be talking to the governor's public health conference, the keynote address on resilience and recovery. And that's important to be looking at too.
Great. Thanks again. Good luck with that keynote. I'm sure we'll talk to you soon.
Okay, so quite a few questions still. Carla has a question about monoclonal antibodies and convalescent plasma. She says that she understands, and correct any thinking, that you have to wait 90 days to get COVID vaccine if you've had that. But she goes, what if the reverse happens? What if you get the vaccine, but you get COVID? Can you receive any of those treatments? And would a patient need them?
Yeah, she's absolutely right. If you have received your first dose or are going to receive your first dose, you need to wait 90 days after getting your monoclonal antibody therapy. We really aren't using convalescent plasma anymore, but monoclonal antibody therapy, if you receive that, you need to wait 90 days to start vaccination or get your second dose. So you can delay that second dose. That is in the guidance. What if it happens the other way? If you are within 15 days from your first dose of Moderna and Pfizer vaccine, you can get the monoclonal antibody. If you are more than 15 days out from that first dose, then you would not be eligible to get the monoclonal antibody therapies.
All right. Joe wants to know, any news on the Novavax vaccine?
Nope, I think it's still in those late phase, those phase 3 trials, data collection and analysis. But, we are hoping that will be one more thing that we can use, one more vaccine that we can use.
Cindy wants to know, the average age of hospitalizations, is it younger? And if it is it because the seniors were vaccinated first?
So great question. Also a common question now is a number of people in the community are asking exactly that. So what we have seen here is a definite decrease in the percentage of our admissions who are in the 75 and over age group, with really no change in the 65 to 75 age group. And that is fairly consistent across the state. There's some variation from week to week in the state numbers for hospitalizations. But in general, in that age group of 75 and over, which is the highest age group as far as acceptance of the vaccine, so the age group with the highest percentage vaccinated, we have seen a decrease. What we haven't really seen is a significant change in the younger age group, and by that I mean the 20 to 29 age group. That question keeps coming up. Well, aren't 20 to 29-year-olds being admitted more to the hospital? And the answer is not here. What we've sort of seen an increase in is the 40 to, say, 65-year-old age group. And I suppose that makes sense based on risk factors for severe disease among those who are not yet vaccinated. Now, interestingly, we've talked a lot about Michigan over the past week or two, and Michigan, the Hospital Association there, published yesterday their admission statistics through, I think, the end of last week, or maybe through yesterday, for the month of March compared to the month of February. And so in Michigan, there is an 800% increase in the number of hospitalizations in the 40 to 49-year-old age group, and a 633% increase in the 30 to 39-year-old age group over the number of admissions to the hospital in the month of February. And the other interesting part about the analysis showed that as age increases and as the percentage of each age band that is vaccinated increases, the hospitalization rate decreases. So I think that reinforces the message we've been sharing for a long time now, that both in late phase trials and in real life, vaccines work to prevent severe disease and hospitalization, even in the groups, specifically the elderly, that are at highest risk for severe disease and hospitalization. So there are some good news nuggets buried in there, right? Vaccines work. If you get them, it keeps people out of the hospital. But there are also some concerns in there that the 30 to 49-year-old age group really is what's driving hospitalization increases in the state of Michigan, and likely is also the age group that is really driving transmission in that state. And that's concerning. I think we know that there are a number in those age groups, even here in Kansas, that are hesitant. And it's also very likely that some of those people are hesitant because they had been infected before and feel like they don't need the vaccine now. and the percentage of variants in those new infections in Michigan is also increasing. And so we've actually started to see that a little bit here in our population. By that I mean we still screen every patient for surgery, or almost every patient for a surgery or a procedure for COVID before they have their surgery. And we have seen a number of patients in the past month or so who were positive in the fall, September or October, who are far more than their 90 days out, who are positive and mildly symptomatic again now. We've started to do some variant testing in that population to understand if that's related, this repeat infection is related to variants in our community. And as Dr. Norman mentioned, that overall testing for variants in the state of Kansas is increasing in its frequency. But I think all of that should tell us that, number one, it's likely that younger people are getting infected more. Number two, it's not just the, say, 18 to 30-year-old age group, the questions we keep getting asked about. And number three, there's something to do with repeat infection and potentially variants in that equation that we don't quite understand yet, which I think basically means the same thing we've been saying for a year now, right? Hand hygiene, wear your mask, keep the bubble small, and of course get vaccinated when you can until we have enough of the population vaccinated in each age group to prevent further surges like this. I just said a lot, Dana. Anything you want to add?
No, I think that's a good point. There is good early evidence also that people who've had the infection, especially with mild or moderate symptoms, and they get vaccinated, when you use antibodies as a proxy, you show that their immune system is more robust. Their immune response is more robust if you look at antibody titers, which seem to be higher in those people that have had the infection and the vaccination versus just the infection alone. So that's just one more thing we can use as a talking point to say, even if you've had COVID-19, please get your vaccination.
All right, Isaac has a question. He said, yesterday the CDC director spoke of a sense of impending doom.
Mm-hmm.
He says, personally, he's afraid that her words will be a self-fulfilling prophecy because so many people will hear them and they'll just say, I'm giving up, which is an interesting take. We so appreciate Isaac. What do you think? I mean, you're a physician, so you might have a different take. Don't give up, I'm sure.
Yeah,
that's my message.
Don't give up.
Yeah.
I think Dr. Walensky is great, has been great in that role so far. Those words are a little bit hyperbolic, but at the same time, there is truth in them. I never want to say impending doom, but there is a great concern because we have seen what has happened to some of our brother and sister cities in the United States throughout this pandemic. We see what's happening in Michigan right now. We have seen what happens in Europe. So I think there's a great amount of concern, especially with the variants and lifting of restrictions. We don't want to go backward. We don't want to become like New York, Houston, LA County, all those things. So I think as a nation, we need to continue to be vigilant and do those things that we've talked about.
Yeah, and I would, I guess, echo the please don't give up comments. Yeah. Maybe the choice of words is a bit ominous, but I also think the reality of the situation on the ground, especially from Dr. Walensky, who prior to being CDC director was out there on the front lines and has seen exactly what this looks like in our communities. The concern is very real. Dana mentioned what's happening here, but also Europe and South America. And to be honest, even the states in the Northeast that are leading right now, and leading in a bad way, of course, but leading the nation in the number of new infections per 100,000 residents, the picture here looks a whole lot like every other surge we've seen. And so I think the words of caution are very, very fair. And I know everyone is tired. I know many of us would like to get to a point where we're not thinking there could be another round of serious impact to our communities and another round of things that feel more restrictive when we're hoping to be able to return to a little bit more normalcy. But I guess I would just reinforce the remain vigilant. We're not out of the woods yet. Let's not stumble this close to the finish line sort of message that we've had, because at the end of the day, while those words might be ominous, they're definitely rooted in very, very real concern for our community. They're not meant as scare tactics.
Barbara has a question. She works in a clinic where she is giving the COVID vaccine, and she's worried because more and more she's seeing people say, I can't get in 21 days, or I can't get in 28 days to get the second dose. And she's wanting to know, what do I do about that, and is that okay? She's concerned that prolonging the second dose is going to be a problem.
Well, first, from the science perspective, it doesn't have to happen. Second dose doesn't have to happen right at the 21 or 28 days. From the perspective of concerns about the logistics and difficulty of getting into clinics, second doses are matched very, very carefully to first still. And so while it may not be exactly on day 21 or day 28 that the clinic that you received your first dose in has second dose appointments, within, 14 days even probably, either way, 14 days after is reasonable. You don't want to be too far in front, but a period of time after your sort of due date is very fair and won't impact negatively the efficacy of the vaccine. So I think we know, for example, that some of the county health department clinics in Kansas schedule second dose clinics on specific days of the week and first dose clinics on other days of the week. And that you may fall outside of that window, but that we've not heard really of anyone having trouble getting someone in a very reasonable amount of time that would change the efficacy of their vaccine. So I'm not too concerned.
No, I believe the guidance is you can really get the vaccine or schedule a second dose 4 days either side of that proposed 21 or 28 day. But better if you have to delay it 1 week, 2 weeks, 3 weeks, 4 weeks. That's okay still. You will still have that initial immune system increase and response from that first dose. And then once you get that second dose, that will continue to boost or increase that specific immune response. So I think delaying it 1, 2, 3, 4 weeks is not a problem. But don't forego that second dose. Make sure you get that second dose. That is what is going to provide you the optimal immunity and the optimal durability or long-lasting immunity.
And I think, that's just reinforced by the CDC data released yesterday that talks about in real-world conditions, exposures in real-world conditions in our community, all of the vaccines with EUA are showing a 90% effectiveness at least. And so, good reasons to get it, complete your immunization cycle, whatever that looks like, a single dose for J&J or at the appropriate time, so within reason for the others. Don't forego that second dose if it's part of the prescribed regimen, and don't worry too much if you're a few days off.
So two more questions and then one comment. So Rachel and Nancy want to know, they've been reading and they want to know about that second dose, why we really need it. And Nancy is saying she read that the Pfizer and Moderna, the first dose is coming back 80% effective, and the same can be said of people who had COVID. So why do we need to get that booster? Do you agree with any of that? And
I agree with being able to get the booster. Yeah, again, as we said, that first dose is really going, first of all, that's how the studies were designed. We don't necessarily know the long-term durability because we haven't been doing it for long-term. But that is how the studies were designed. They showed great efficacy after that second dose. That first dose, you really start to get that adaptive immune response, that specific immune response to spike and all of those areas on spike that you create an immune response to. At that second dose, you really start to boost all of those circulating cells, those B cells, those T cells. So that's why it's important. In addition, we believe that that second dose is really the important part for getting that durability, getting that longer lasting immunity to COVID-19.
I think the simple sort of explanation of second doses, think of vaccine doses like training your immune system. So the first time you do something, you could be pretty good at it.
Yeah.
The second time you see it and do it, you're even better. And that's exactly the sort of theory here, that we need that for our immune system to really be trained up to provide the optimum response to an exposure. And so while one may be okay, 2 is definitely better, at least as it's been shown as the studies were designed so far.
Right, and that is to say there are studies now ongoing looking at just single dose as well. So, but right now, as those trials were done, as the data shows, and as the emergency use authorization was okayed, it's in that 2-dose regimen.
Okay, Catherine wants to know, my parents are 85 years old, they're fully vaccinated, and they want to go back to person in church. She wants them to wait until more people are vaccinated. She wants to know what you think.
You know, I think that's risk mitigation. We are coming, to Easter Sunday. A lot of different churches, Christian churches, are going to be holding services. I think that's a great thing compared to last year. If you can go to your congregation and it's safe, most congregations or parishes we know are doing things to be safe, and that is spacing, not seating everybody in every pew. They are also offering, car masses where you can listen in your car. But you have to understand the risk, and all of these things are done to mitigate risk. I think masks are still pretty prevalent in all the churches, so understand if that is in your church, which it should be. Then if you're vaccinated and everybody is masked and you're spread apart, I think that risk is going to be greatly reduced compared to if those things weren't occurring.
Okay, and the last comment comes from Donna Pittman at Channel 9 News. And she says, Happy Doctor's Day to all the docs that keep us informed daily on this briefing. We agree. We are grateful. And so the team arranged for Chef Eric to come back on and present you on behalf of all of our doctors here at the health system. We wish we could give this to everyone. I know there's going to be a lot of celebrations going on, but Chef Eric, tell us what you prepared for our special doctors.
Well, what we have here is a homemade apple turnover. Jamie Rose, one of our supervisors over at Cambridge, just made this, took it out of the oven maybe 7 or 8 minutes ago. Cookies, freshly made chocolate chip cookies, came out of the oven about 8 o'clock. So just a big thank you from not just dietary and support service, but everybody here at the hospital for the valuable work that you do every single day and what you do to make it happen. So thank you.
Well, thank you very much.
Chef Eric, we love sugar for breakfast.
Thank you to everybody. Yeah, don't let Dr. Robbins see this.
Right, our
Just like I don't tell my dermatologist when we go out into the pool.
Sometimes, yeah.
Not going to tell the diabetologist when we're having cookies for breakfast, but thank you very much.
Thank you, gentlemen.
Greatly
Wonderful
appreciate
day.
it.
Thank you.
And we love having you back on, Chef Eric. Thank you so much.
Thank you.
A little bit of sugar, I think, doesn't hurt you just you bit. We know
little
that both
bit.
you
No,
guys
it'll
are
be fine.
very, very health conscious,
That's
but
right.
we hope that you appreciate it in the spirit with which and can accept it on behalf of all of our physicians here at the University of Kansas Health System and Cancer Center. We love you guys.
Thank you.
Thank you.
You know, we do all of our colleagues 100% every day. Get up and do it, and enjoy doing what they are doing to help people and improve their quality of life.
You know, it is, I think, important for us to say out loud today to all of our friends and colleagues here on our medical staff, but also to all of the physicians in our community who have worked tirelessly over the last year and really across the country. It is important for all of us to say thank you as well. While we're here doing what we can via this vehicle, we know that there are so many people out there doing so many things to make sure that our communities are safe and to make sure that we can return as quickly as possible to the things that are important to us in a way that feels just a little bit more normal. We're happy to play our small part, but we know there's many, many, many other things going on out there that are just as important or more important.
And the physicians relations team asked me to tell the community, if you have a favorite doctor here at the health system or the cancer center, and you want to send them a card, if you will mail it in care of media relations to my office, I will make sure that those cards get hand-delivered to your favorite physician. So just send them to media relations, your doctor's name in care of media relations here at the health system.
Yeah, so many great primary care providers, family medicine, internal medicine, surgeons, specialists. Please do.
And those notes do mean a lot. Heartfelt, handwritten notes are a big part of how we say a very personal thank you. So take advantage of that if you have someone you'd like to recognize. I know that it would be very much appreciated. All right. Well, before we dig into all the stuff that smells so good, that can't come across the screen, the camera, but the cookies, I think, are what I keep smelling.
Yeah, it
I'm going to
smells good.
find me one of those really quickly. But tomorrow, we'll have Dr. Love back to talk allergies and COVID-19. You may have heard of research pointing to a longer pollen season, and you're not imagining it.
Yeah.
Science does show that the pollen season has grown 20 days longer over the past 3 decades. The study involved tree pollen, and Dr. Love will join us to talk about what that means to you and remind us all how to tell whether your symptoms are truly allergies or perhaps COVID-19. So Dana, final thoughts this morning?
Yeah, I'd just like to go back to Texas a little bit, what you were talking about. I think it would be myopic and short-sighted to associate causality of lessening restrictions and stopping masking with a decrease in the cases. We know that's not true. That hasn't been true since the inception of the COVID-19 pandemic, and I don't see why that would change now. So continue to mask, distance, not meet in large groups, get vaccinated. Then we are much closer, everybody, to being able to do that and do those things that we want to do and keeping everybody safe. And I would also just like to say happy birthday to my daughter today, as well as my 98-year-old Grandma Stella, who has thus far survived the COVID-19 pandemic and has received both of her vaccination doses. So we're looking forward to hopefully another good year with her and actually being able to see her this year. That would be a good thing.
Yeah, 2 very special happy birthday wishes. And I'll just end with a reminder that vaccines, especially in Kansas, but next week in Missouri, as they open up to anyone from an eligibility standpoint, please do everything you can to get yourself vaccinated just as soon as you can. If you remain with specific questions, please do reach out to your physician or your medical team. Know that everyone, regardless of their organization, would be happy to spend time with you to help you understand exactly why it's important for you in your specific circumstances, and to also help address any concerns you may have about receiving that vaccine. So stay safe out there, and we will see you tomorrow with Dr. Love.